some teams from the USAID Washington and Zambia offices, and also CDC Atlanta and CDC Zambia. So dear team, you're all welcome. Okay, so I would also like to just recognize our team of experts that are going to be helping us navigate our session today. This is Dr. Priscilla Mlenga, Ms. Miriam Selisho, Madam Maureen Muzumara, and also Dr. Moviana Bewe. So just a few reminders as we begin. Do kindly ensure to make sure that your mics are on mute when not in use, and also to register with the registration link that will be shared periodically by the IT team in the chat. Also, we do have an onboarding iEcho, how do I call it? We have a new registration system that's actually going to be working, and I think we'll talk about it some more at the end of the session. But the beauty about it is you will be required to only register one time, and it will automatically send reminders when we have a session that is due. So without further ado, I will just share the screen and hand over to Dr. Piri to proceed with our session today.
Okay, so thank you, Doc, and good afternoon, network. I was already introduced, Dr. Piri Chimika. So today, once again, it's a pleasure to discuss a very important topic under PMTCT. We had this topic previously, but I think we didn't have enough time. Hopefully today we can have time to interact in terms of answering some of the questions. So our focus look at the management of an HIV-exposed infant, as already introduced. Yes. So these are the learning objectives. The fourth one won't cover it because of time, but in case people may have questions, we should be able to address colleagues that are on the expert panel should be able to address some of the questions next. Okay, so we have first 4 questions.
Okay, so we have our first 4 question. I will just share the question, and then we can begin to pull in as I read out the question. Okay, so our first 4 question reads, which of the following is not an effect on HIV-exposed infants due to in utero exposure to maternal HIV? So the question again, which one of the following is not an effect on HIV-exposed infants due to in utero exposure to maternal HIV? So the options: A, increased risk of low birth weight; B, decreased infant mortality; C, intrauterine growth retardation; and E, reduced head circumference in early life. So dear network, please feel free to call in. Dr. Piri, we appear to already have a contender for which we, but the network feels the answer is. So we'll give it a few more seconds and then we'll close the poll and share the results. So dear network, please do feel free to call in. We are just about to get to the 50% mark for those that have called in among the ones that are logged in. Okay, so we just got about 50% of the vote of the polls. So we'll close the poll at this point and then share the results, and then Dr. Piri will proceed with the presentation. Okay, so from the ones that called in, the network, about 50% of the network feel the answer is B, but I'm sure Dr. Piri will shed more light on this one as he proceeds with the presentation.
Okay, so thank you very much, and very interesting polling there.
Yes.
Yeah, at least democracy majority. So that was the correct answer, but we'll again emphasize more around that. So the first part, I felt that we should understand that a lot of studies have shown that the babies that are born from mothers that are living with HIV seem to have some issue or challenges compared to those that are born from mothers that are HIV negative. Okay, so some of these effects could be said to be short-term and others could be long-term. So this applies to both those that are HIV exposed, infected, and those that are HIV exposed but not infected. So this is very important for the network to understand, because this is very crucial when we are following up these babies. We need to bear in mind that even if this baby is not HIV infected, but the baby is exposed, is still at risk of some of the poor outcomes. So generally, studies have shown that exposure to maternal HIV infection actually puts the developing fetus at risk of the pregnancy outcome being preterm, or indeed the growth of the baby in utero could be compromised. So some of these babies could have intrauterine growth restriction. Next. Okay, so furthermore, for the mothers that have advanced HIV disease and pregnant, some of the other adverse effects that we have noted from the babies that are born from such mothers, that these are infants that seem to have high risk of having morbidities and also increased risk of mortality. And also during their early life, maybe in the first year, they seem to have issues around the weight. And also when you do other anthropometric measurements, such as the length and head circumference, they seem to be lagging behind compared to those babies that are born from mothers that are HIV negative. And the other one that I already mentioned is that these are babies that many times are at high risk of having intrauterine growth restriction, and most of them may record low birth weight when delivered. Okay, so we move on to the next poll question.
Okay, so for our next poll question, okay, I'm just launching the question now. So the question reads, which one of the following is false? Which one of the following is false? So A, in Zambia, all HIV-exposed infants should receive cotrimoxazole prophylaxis from 4 to 6 weeks old. B, the recommended ARV prophylaxis for HIV-exposed infants in Zambia is AZT, 3TC, and NVP. C, according to the current national guidelines, all HIV-exposed infants should receive ARV prophylaxis for 24 months. And D, all HIV-exposed infants should be assessed for TB on every visit. So dear network, please feel free to call in. There are no wrong answers. We are all here to learn. We seem to have a very good participation in terms of number of people that have actually logged in, but we're still not getting the numbers for the ones that are calling in. So please feel free to call in, and all will be clarified as we go ahead with the presentation. So give it a few more seconds, and then we'll close the poll and then share the results. Okay, so we have about 60% of the network polling in. I will end the poll at this point and then share the results. Okay, so for this question, Dr. Piri, most people think the answer is C. We have another percentage, slightly bigger, thinking the answer is A. I'm sure you will clarify this for us.
Okay, so thank you very much, Doc, and interesting points there. So we start out, we're going to understand why should we labor to understand and share knowledge around the management of HIV-exposed infants. So much of the interventions that are put in place are around the 4 goals of management of HIV-exposed infants. So we want to prevent postnatal transmission of the HIV from mother to the newborn, and also to identify those that could have gotten infection at early stage so that appropriate interventions are put in place, and also to prevent opportunistic infections with that background knowledge that we learned earlier on, that all HIV-exposed infants are at risk of morbidity and mortality, whether they are infected or not infected. As long as they are exposed, they're still at risk of having some infections, which we refer as opportunistic infections, because their immune system is suboptimal. And then we also want to make sure that we maximize the family health and well-being. Remember that when a baby is sick, or indeed an exposed infant is not well, the whole family is affected. So we need to make sure that the whole family is taken care of, including the parents. Next. Okay, so much of our discussion that I'm going to share is based on the national treatment guidelines for Zambia. I know WHO has put up some recommendations, but you will see some of them that we have in our national guidelines are based on our scenario on what is happening on the ground. So generally, all exposed, HIV-exposed infants are expected to be put on ARV prophylaxis from birth. And our recommended regimen or combination of ARVs is azdovudine, lamivudine, and nevirapine. And I think many of us are familiar with this, but we need to make sure that we understand when to start and when to stop, okay? So it's important to acknowledge that Zambia is a breastfeeding nation, okay? And according to our guidelines, all babies that breastfed, or the exposed infant, HIV-exposed infant that breastfed are expected to receive the ARVs prophylaxis for a minimum of 12 weeks, right? So at 12 weeks postnatally, this is also many times coincides with when we do the follow-up viral load test for the mother. If the mother achieves viral suppression, in this case, according to our national guidelines, we're talking about if the viral load that comes through are less than 1,000 copies per mil, then we can stop giving this baby the prophylaxis. However, if the mother still has viral load results of more than 1,000, then we have to continue putting this baby, giving this baby ARVs, which we refer to as extended ARVs prophylaxis. For the mothers that are not on ARVs yet, okay, so such babies that are born from a mother that is living with HIV and the mother has not started treatment, we still need to offer extended ARVs prophylaxis to such babies as long as the baby is still breastfeeding, because the exposure is still there. We need also to make sure that we continue counseling this woman to start ARVs treatment. Next. Okay, so this is what I spoke about earlier on, okay? So there are situations where we may have mothers of exposed infants, the newborn, who are never exposed to breast milk for different reasons. For example, the mother decides not to breastfeed. She is willing to offer exclusive replacement feeds, or indeed maybe the mother, for some reasons, unknown reasons, maybe dies. Or so such babies, from birth, there's no further exposure apart from during labor and delivery. So these are the babies that we are supposed to give ARVs prophylaxis for a period of 6 weeks. And you know that this is the time that coincides with the NAT test, which we are going to discuss more. Okay, the fact that these ARVs have some toxicity to body tissue, particularly hematological toxicity, we need to make sure that we do routine full blood count to focus to look at the HB. Okay, we know that as Dovidin can cause anemia and also neutropenia. So at birth, we need to make sure that we collect baseline full blood count, which we'll use as a reference as we do the follow-up full blood count. So we expect that after 4 weeks from birth, we need to do a follow-up full blood count, and we can continue doing it monthly as long as the baby is on the AZT-based ARV prophylaxis. So this is just a summary, just to help you understand in terms of the dosing of the nevirapine as well as the AZT3TC fixed dose that we use. This SOPs or job is there in the current treatment guidelines, and many of the sites have this displayed. So just to remind you that we need to ensure that we give the correct amount based on the weight of this baby. Next. Furthermore, it's important for us to just remind each other in terms of reconstitution of this dispersible tablets, which is a fixed dose of AZT3TC, and we seem to have drugs.
Okay.
Thank you very much.
Withdraw. Apologies for that, dear network. We did drop out for a few seconds there, but Dr. Piri will proceed with the presentation.
Thank you. So I was just trying to emphasize that we need to ensure that we share this important knowledge around as we offer adherence to the caregivers. So as healthcare workers, we need to understand how to reconstitute, how to prepare the dispersible tablets and how long it's supposed to be kept. So it's important that we encourage the caregivers to reconstitute these drugs on a daily basis, right? This is highly recommended, and also to ensure that before it's offered to the baby, they have to shake the suspension so that it's evenly distributed. And take note that if you look at the table that I earlier shared, I don't think it covered for those babies that have weights below 2 kgs. So it's important that as we calculate the dosing for these babies, we need to use the 2 milligram per body weight for nevirapine, as well as 2 milligrams per kg for AZT3TC. This is very important because many times we receive calls, okay, in terms of dosing for these are usually the low birth weight or the preterm babies. Okay, so again, it's very important that the caregivers are given necessary information. So we need to endeavor to educate them on the reconstitution of these tablets, because if we don't do the correct thing, we may not see the effectiveness, the optimal effectiveness of these drugs in the prevention of HIV transmission from mother to child. Next. Okay, if you remember in our poll question, or in the early slide that we shared, we alluded to the fact that studies have shown that the babies that are born from mothers that are living with HIV at a higher risk of morbidity and mortality compared to those that are born from HIV negative mothers. So we need to ensure that we prevent some of the common opportunistic infections that claim the lives of these babies. One of them is the PJP, okay, pneumocystic jerovic pneumonia infection. So we need to start these babies on cotrimoxazole. We can start them from 6 weeks, 4 weeks, between 4 weeks to 6 weeks. But we know that our guidelines stipulate 6 weeks because this was convenient, because this is when the babies come for the 6 weeks EPI in terms of the immunization. But in an event that you come into contact with the baby that is already 4 weeks, you don't need to wait for 6 weeks. You can always start the cotrimoxazole. Such situations like the baby is admitted in the hospital or comes through for other ailments, and you identify that it's an exposed baby, is now 5 weeks. Let's not wait for 6 weeks. You can start the baby on cotrimoxazole. Next. Clinical assessment. This is also important just to make sure that we identify those babies that could have underlying conditions. Okay, so we need to get appropriate history checking in terms of how the baby is growing, how the baby is taking the medication, physical examination. Let's do appropriate anthropometric measurements to ensure that the baby is thriving, right? And also let's check that the baby has, or the caregiver has ARVs, and also if it's eligible for, in terms of age, for cotrimoxazole prophylaxis. In an event that we pick something that we may not be able to manage at our level, let's ensure that we refer to the next level. And remember, both the HIV exposed and unexposed babies, they need to receive the immunizations according to our API program in Zambia. Next. In addition, let's ensure that we evaluate for TB, because these infants, the exposed infants, they are also at risk of getting TB disease. So we need to establish if at all there's anyone in the family or in the recent past who's been in contact with the baby who has had TB or who's been newly diagnosed with TB. We need to assess according to our national guidelines to establish if the baby has active TB disease. If not, then they may be eligible for TPT. Okay, and also some features could indicate that something is not going on in this baby, not just HIV infection, but presence of TB. Some of the things that you need to look at is the weight gain in terms of the velocity weight gain, and also if the baby is having any cough or any fever of any duration, think TB, because you know that TB is one of the common diseases that is affecting our infants. As I mentioned earlier on, if the baby is eligible for TPT according to our national guidelines, please don't hesitate. Let's start such babies on TPT prophylaxis next. We now have the next poll question.
Okay, thank you, Dr. Piri. So we'll launch our third poll question, and we'll read it out, and participants can feel free to poll in. So our third poll question reads, concerning early infant diagnosis testing, which of the following is true? A, in Zambia, confirmatory test for HIV infection in children more than 12 months old is serology test. B, the virologic test done at birth is able to pick the HIV infection that occurred during labor and delivery in a newborn. And C, virologic rebound in HIV-infected infants, starting treatment early is expected to happen within 8 months of interruption in more than 99% of HIV-infected infants. I will go through the options once more as the network pulls in. So our first option is in Zambia, confirmatory test for HIV infection in children more than 12 months old is serology test. B, the virologic test done at birth is able to pick the HIV infection that occurred during labor and delivery in the newborn. And C, virological rebound in HIV-infected infants starting treatment early is expected to happen within 8 months of interruption in more than 99% of HIV-infected infants. Okay, so we only have about 26% of the network polling in. I would encourage all of us to poll in. And just another reminder, please do ensure that you register with the registration link that is being shared in the chat by our IT. It is very important for sustenance of our ECHO program. So we'll give it a few more seconds and then we'll close the poll and share the results. Dr. Piri, this one seems to be a little bit hard. Most people are shying away from responding. Okay, so we have about 53% of our network having called in. I will end the poll at this point and share the results so that we can further discuss. Okay, so Dr. Perry, the majority of the network, about 39%, feel the answer is A, with about 34% thinking the answer is B, and about 26% thinking the answer is C. So you will clarify this for us.
Thank you. And I can see there that I may need to emphasize more on this early infant diagnosis. Thanks for that attempt, network. So according to our national guidelines in Zambia, the confirmatory tests. So when we say definitive diagnosis, we are looking at what tests are we using to confirm HIV infection in an exposed or in an infant. So for all babies that are under the age of 24 months, okay, the confirmatory test in Zambia for HIV infection is NAT, okay? I repeat, I know WHO talks about 18 months and below, but in Zambia, because it's a breastfeeding nation, and we know that maternal antibodies may still be in circulation up to about 24 months, what we adopted is that for HIV confirmation of infection for babies, the confirmatory test for all babies 24 months and below is virologic test. And those above 24 months of age, we use the serological test, which is the antibody testing. So I repeat, network, so that there's no confusion, okay? We can only confirm the HIV infection for babies that are 24 months and below. For Zambia guideline, we use the virological test, right? PCR, if you want to call it that way. And for those babies that are above 24 months, yes, we can confirm the HIV infection using the rapid tests or the serological test, or we can call it antibody test, okay? So we know that the baby can get infected at different stages, including in utero, during pregnancy, during labor and delivery, and as well as postnatal through breast milk. Okay, so in terms of testing, we know that in Zambia, we encourage that we do the birth test, which is the NAT, and this NAT, we are trying to identify those babies that were infected during pregnancy. The NAT that we do at birth is not able to pick the infection that the baby could have acquired during labor and delivery because the time is too short. So get it clear that the NAT test that we do at birth, the purpose is to identify early identification for those that could have gotten infection in utero, that is during pregnancy, okay? Next. So this just summarizes in terms of the testing algorithm and testing timings, all right? So first NAT that we do is at birth. Then the next one, we know that there may be those babies that could have gotten the infection during labor and delivery. This can be picked at 6 weeks, all right? And then the follow-up test is as shown on the table. So up to the age of 9 months, the first test that we recommend according to the guideline is the NAT at those different testing timings. Beyond 9 months, we first need to screen the baby with the serological test. If the serological test is positive, that's when we follow up with a NAT just to confirm the infection, right? So that is applicable to all the babies that are under the age of 24 months. Beyond 24 months, we can treat them like the way we do in adult population, or the babies that are above 2 years, we use the serological test. If it comes out positive, that may mean that the baby is HIV infected. So that's the confirmatory test for those above 24 months, serology. For below 24 months, we use the NAT. Next. However, we may have some situations, and I think we've had some calls around this, so I thought that we could discuss and how we proceed in such scenarios. So even for early infant diagnosis, we can have what we call discordant HIV test results, right? The principle in terms of definition is also similar to what we do when we are using serology for the adult population. So this is applies to where we have the first NAT which comes out positive, okay? And according to our guideline, when the first NAT comes out positive, we need to initiate the baby on ART, okay? And then we do collective samples for a follow-up NAT, that will be the confirmatory NAT. Now, in an event that the NAT that, the second NAT that we got comes out negative, right? That such scenario is what is referred to as discordant HIV test results, okay? Otherwise, we may have situations where we have, where the first and the second test agree, meaning that the first NAT was positive and the follow-up NAT, which is the confirmatory, is positive. There we don't have issues. We continue with the baby on treatment. That confirms that the baby is HIV infected. However, when we have discordant test results, how do we proceed? So what you are supposed to do is you shouldn't stop the ART that you started based on the first NAT. So you cancel the caregiver about the results, right? And then you collect another NAT. This will be the third sample where you want to see now what will be the outcome, okay? So depending on the outcome of the third NAT, okay, a decision has to be made. So if the third NAT comes out positive in this case, then you continue with the treatment. However, if the third NAT comes out negative, just like the second NAT, okay, here what we need to do is what we call ART treatment interruption. So we encourage the providers to interrupt, in other words, to stop the treatment for a moment. But before you do that, there are things that you need to make sure that they are in place. Next. Okay, so you need to ensure that you examine the baby thoroughly, that there's no pointers to early HIV infection, right? And also you need to have a clear plan. You need to explain to the caregiver so that they understand what you are doing, and there should be a clear plan. And also you need to establish contacts, right? Phone numbers and addresses, because you may need to contact them at an early stage for some interventions that may need to be done, right? So if these have been put in place and you have a discordant results, a third NAT is negative, and the baby was started on ART, you can interrupt, okay? So how long are you going to do this interruption? Next. Okay. So studies have shown that for babies that are HIV infected and have been on treatment, when there's treatment interruption, right, more than 99% of them, and within the period of 8 months, there is recorded viral rebound, okay? So with this information, even the follow-up of such babies after you start the interruption, we need to follow them up for a period of 8 months. So I'm going to explain what we need to do during these 8 months, because we need to follow up with various tests at different times, okay? This was very important. That's why I emphasize that we need to have contacts for the parents or the caregivers, so that once we pick within the 8 months, there's evidence of viral rebound, we quickly get in touch with them so that we restart this baby on ART. During this period, we need to ensure that we physically examine the baby for early signs of HIV infection or any other OIs that the baby may have, right? And you may have two scenarios. Within this period of 8 months, some babies may still be breastfeeding beyond the 8 months of follow-up, and others may stop breastfeeding during the 8 months of follow-up, or indeed before the end of 8 months follow-up. So we're going to summarize in terms of what we expect to do to such babies in terms of the final test. Next. So this is a summary that was gotten from a WHO guideline. So what you can see there is we start from the point of interruption, ART interruption, when you have the third NAT that was negative with the same results, the second NAT which was negative. So you stop you interrupt the treatment that is stopping the ART at this point, and you explain, you make a plan that we're going to follow up this baby for the next 8 months, okay? So for the first, the one that I've shown here is where we have this baby in a scenario where this baby stops breastfeeding beyond 8 months, okay? So in terms of the follow-up test, after you stop the ART, 4 weeks later, you need to schedule, have a viral load test, okay, and a NAT. So remember, you need to do both, NAT as well as a viral load, okay? If at these 4 months, NAT is negative, viral load is undetectable, okay, you still continue following up this baby, and you plan to do the next similar test at 4 months after the time you started the interruption. If at 4 months, the results of NAT and viral load, NAT is negative and viral load test comes out undetectable, you continue following up this baby. The next scheduled test that you do is at 8 months. And remember, we agreed that we need to follow up this baby for 8 months because evidence has showed that if this baby was truly infected, within these 8 months, more than 99% of babies will record viral rebound. So at 8 months, you need to do the NAT and viral load. If both are negative in terms of viral load undetectable and NAT is negative, what you need to do now, you don't have to do a routine follow-up test, but you wait for this baby to stop a time when the baby stops breastfeeding. So you time in such a way that 3 months after cessation of breastfeeding, you do a serology test. Depending on the serology test results, and also depending on the age of this baby, then you can do a final test. So for example, if this baby is beyond 24 months and serology test is negative, it means this baby is not affected. But if the baby is below 24 months and rapid test is positive, you can still follow up with another NAT, just like in the general algorithm. The next one, similar, but the only difference is that this is where the baby stops breastfeeding during the 8 months of follow-up, or indeed by 8 months of follow-up. So in this case, you don't need to do like we did previously, but just have to time in terms of when the baby stopped breastfeeding, okay? So the final HIV status can actually be done with NAT, which can be performed at least 6 weeks after the cessation of breastfeeding, because this entails that this was the last time the baby was exposed to HIV from the mother through the breast milk. Next. Okay, so in terms of summary, based on what we have discussed, it's important for us to understand that babies that are born from mothers living with HIV, whether HIV infected or not, they are still have higher risk of morbidity and mortality. Sorry, that wasn't included here. And also to ensure that we prevent development of some OIs based on our goal of management of HIV prophylaxis. This includes both pneumonias such as PCP or PJP and also TB. We need to assess clinically in terms of growth and development of these babies, because as we know that they are at high risk of failure to thrive, and also maybe they may lag behind in terms of some anthropometric measurements in terms of length, head circumference, and all those things. So, and you know that some of these could be early features of HIV infection. So we need to ensure that we interpret these results appropriately, okay? Just a reminder that the care of HIV exposed infant does not just start at birth, but is second now from the time the baby and the mother is falls pregnant. So we need to ensure that the mother is put on ART that is identified for to have living with HIV, and also promote good nutrition in this mother, and also ensure that we treat OIs, including TB in this mother, including syphilis, of course. Thank you very much. This is my last slide. Yeah, no.
Thank you so much, Dr. Piri. I think most of our core questions have been answered in the presentation, and I think a lot of gray areas with regards to managing our HIV-exposed infants have been clarified. So we are going to take some questions. So already we have Moses Makondo who's raised their hand. Please do go ahead as we go through the chat as well to see some of the questions that have been asked. Moses, you can proceed with your question.
Thank you very much, Tim. Good afternoon, network. My question is, I've received reports from caregivers who say babies are vomiting AZT3TC niverapine. So in such a case, what do you do, and is there an alternative? Thank you.
Okay, we'll take another question from the side, and then maybe we'll talk 2 questions, and then we'll look at some of the questions that are in the chat. Desai?
Good afternoon, network. Good afternoon, network. My question goes to the doctor. I received a baby at the facility who only breastfed 2 weeks, and the mother was non-positive, died in 2 weeks, and the baby breastfed for 2 weeks. They only brought the baby at the facility at 6 months. How do you manage the baby? Thank you.
Okay, thank you very much for those questions, Moses and Desai. Dr. Piri?
Thank you. Very interesting questions there. Okay, so the first one, thanks for sharing with that. So, well, I think we used to record quite a number of babies spitting the ARVs when we were using the Pinava because of the beta test. But it's interesting to hear that even the AZT3TC neverapine, the babies are still, in this case, they're not spitting, but they're vomiting. Okay, so I think it will be very important first and foremost to understand in terms of the preparation of these drugs, who gives the drugs to the baby, how it is given, okay? And also to examine these babies thoroughly, because the vomiting may also be associated with some OIs that the babies may have. Maybe the baby may have oral thrush, or indeed may have some GI issues. But, okay, what we can, if you establish that truly the baby is vomiting after taking the medication, you can reduce in terms of the quantity, right? For example, you're supposed to give maybe 5 meals in the morning. So you can split maybe 2.5 meals first part, and then the second 2.5 meals can be given maybe within 30 minutes so that the baby can finish the whole amount. Because sometimes when you give a lot at once, some babies can vomit. But what is key is, first of all, to establish how this baby is given the medication, how it is prepared, and also just to make sure that there's no any underlying infection that is actively the baby has. Some babies may have other issues or abnormalities which we need to pick early that could be associated with this vomiting, but many times maybe the baby is unwell. So we need to pick if there's any active infection. Yeah, I know probably the experts on the panel may add something in terms of management of such babies. But let me quickly address the second one, where we have this baby that breastfed for 2 weeks. And unfortunately, the mother died, and the baby was brought into contact with the facility at 6 months, if I got the history well. So other issues that I'm not sure whether this baby was on prophylaxis, whether the mother was on treatment, but this is the baby that has come through to you at 6 months. So what do you want to do? You want to establish whether the baby is infected or not, so that you quickly put the baby on ART. Okay, and in such scenarios, you go straight away to a NAT. Okay, so you can collect blood for NAT. Okay, you do NAT. If you have point of care, you do. And these are the babies where you can expedite the test so that you have the results as soon as possible. Okay, so if the NAT at 6 months is negative, and you know that the last exposure to breast or to HIV was through breast, which has been 2 weeks when the baby was 2 weeks old, there's no further exposure, and most likely this baby is uninfected. So the only thing that you can do and wait is to do a final test at 24 months, which is a serology test. However, the baby has to receive the the immunization, and keep on examining the baby physically just in case there's either signs of HIV infection in such babies.
Okay. Thank you very much, Dr. Piri. I hope your questions have been answered. So we'll take two more questions from the chat, and I'll call upon Dr. Obiana Mbewe to respond to these if she's with us on the call. So the first question is from Matthews, and it reads, what is the assurance that the child won't get the virus when the mother has 999 copies of HIV and the child has been breastfed for 12 weeks and you stop the HEI prophylaxis? I'll just repeat that quickly. What is the assurance that the child won't get the virus when the mother has 999 copies of HIV and the child has been breastfed for 12 weeks and you stop the HEI prophylaxis? So I'll read out the second question and then maybe we can take these two before we go to the other questions. So the second question is from Leonard Banda, and it reads, what do we need to consider when stopping AZT3TC and verifying prophylaxis? Is it just any maternal viral load suppression or undetectable viral load? I'll repeat that quickly. What do we need to consider when stopping AZT3TC and verifying prophylaxis? Is it just any maternal viral load suppression or undetectable viral load? Dr. Mbewe, if you're with us, would you kindly address these two questions?
Thanks for the questions, and thanks, Dr. Piri, for the presentation. Very informative. I think the two questions are related. According to our guidelines, when a mother has a viral load which is below 1,000 copies at 12 weeks, the guidance is that we can stop the prophylaxis. But of course, the mother has to maintain adherence and ensure that the viral load remains suppressed below 1,000. There's no 100% assurance that the infection will not be transmitted. You will get the rare infant who still gets infected, but the chances of transmission are indeed very, very low at these viral loads. So the idea is suppress the virus in the mother, but she has to maintain adherence and remain suppressed throughout breastfeeding. Otherwise, the baby can still get infected. So you need to support the mother to maintain adherence and keep monitoring the viral load every 3 months so that you are sure that she is suppressed to protect the baby. But it's important in counseling, as you're counseling the mother, to know that these are probabilities. Chances of infection are really reduced to the very minimum, but we are not going to say it's 100%. But it's been shown to be very effective, and we are having very few babies being infected, below 1%, usually around 1% to 2%. Thank you very much. I think the two questions are related, so unless there's something that's not clear.
Thank you very much, Dr. Mbewe. I think you've addressed both questions very well. So we'll get another question from Kelvin Chala from Chinsali. Kindly unmute and give your comment or ask your question. Kelvin Chala.
Thank you very much, Doc. Good afternoon.
Good afternoon.
My question or concern is on the testing schedule, which we have for HIV exposed infants, which is not the follow-up tests, which is not coming out in the updated DHIS2. So I wanted to find out if the component of the follow-up test, let's say the retest at 6 weeks, 6 months, you would find that that component was removed from the DHIS2. We only have the initial test at each testing point or timings. I don't know if that component was removed because it is not really monitored, but I think it's an important component to be reconsidered or to be re-added to the DHIS2. Because like that, I think we'll be losing out these exposed infants in as much as we want to follow them up, because it was very easy for us to be monitoring the way that the children are being followed up. So I wanted your guidance on that one, Doc. Thank you.
Thank you very much for that question. I'll call upon Mr. Chimuka Sianinda, if you're on the call. I think this one is related to monitoring and evaluation and data. If you're on the call, kindly respond to that one.
So, sorry, Doc, I just had the DHIS2 and also the tracking of the children. The other part, I could have missed it.
Okay, Mr. Kelvin, just quickly, in under 30 seconds, just ask your question once more so that Mr. Chimuka can give an appropriate response. Mr. Kelvin.
Maybe just to assist him.
Okay, maybe.
Yeah. So Chimuka, Mr. Sianinda, I think the concern was, on the follow-up test for the HIV exposed infants. So he alluded that in the new DHIS2, these follow-up tests have been removed. They're not there, but his concern is that you'd like to reconsider, you people to reconsider if you could bring them back in the DHIS2, because they really help them to track and inform them in terms of final outcome of the exposed infants. So it's about the follow-up test for the HIV exposed infants that are missing, that are not there in the DHIS2. Thank you.
So thank you very much, Doc. I think we were limited based on the space we had on the form. I should make mention, actually, the design was for us to be able to have the samples being collected. We look at the cross-sectional and also the outcome. We're supposed to collect three things. Due to the limited space we had, because there were so many demands to be on the HIA2, what we were asked was to drop one. That's how we dropped the testing I mentioned, but we did not lose all entirely, because currently, especially when it comes to the EID test, we already have the dicer, which is able to capture the test. I think maybe what's just now needed is to engage IHM so that people can be given the rights to dicer, because all the tests which are done are linked. Even the tests, I now understand that even the tests which are coming from the gene experts are also being transmitted to the dicer. So what was agreed was that since there is already a system which is able to capture the NAT test, especially from 0 to about 11 months, those who are having the subsequent test during this period, it was agreed that with the limited we had, we may need to transition capturing that, the checking of that data, we may need to check from the dicer. So that's one comforting part. Then the other part also, I think Dr. Peel may have touched on it, is that the program, the PMCT program, what they want us to start now doing is that for facilities with smart care, we're now likely to start using the PMCT form, which will also be able to give us the results we are interested in. So the goal we want to move to is that the DHIS2, or let me just say the HIA form, will be more of high-level indicators. Then the program-related indicators, we want to move to smart care, which will be now where we'll be able to collect as much as possible. So it was an issue of constraint with space on the HIA form, which led to the removal of the testing. But nonetheless, we are supposed to provide the credentials to the DHIOs and probably the facilities for them to be able, especially the DHIOs and also the provincial, for them to be able to go in the dicer and be able to get this data. In the interim, what has been considered is probably maybe in the next quarter, we'll be able to, before we give the credentials to our DHIOs, I think the team from national level should be who also have got the credentials, will be able to go in the system, mine the data on a quarterly basis and provide to the SHIOs, who should also be able to transmit that data to the various DHIOs so that people can be able to access this data. I submit, Chair.
Thank you very much, Mr. Sianinda. So we'll quickly take in maybe 2 or 3 questions before we move on to the next item in view of time. So I'll read out the next 3 questions, and maybe Dr. Perry and Dr. Mbiano could take 1 question each. So after how long do we repeat the test results in case of discordant results? This question is coming from Kotsana. I hope I pronounced that correctly. Dr. Perry?
Thank you. Thank you very much for that important question. So in terms of the timelines between the tests that needs to be done, so remember, once we establish that we have discordant test results based on the NAT, meaning that the second NAT is negative, the first NAT is positive. Okay, so you continue the baby on ART, you collect sample for the third NAT. Okay, so now in terms of how long in between, so when you receive the results for the second NAT and it's negative, immediately you come in contact with the baby or you call the baby, you collect the sample immediately and send to the lab. Okay, when the results come out negative, okay, you need to decide now, because you need to decide with an intention to interrupt the ART, as long as those conditions that we discussed are met. Make sure that the contacts details are well established and the baby does not have any signs of HIV infection. So you interrupt for the next 8 months. And the follow-up test within these 8 months are such that the first NAT, so you'll be doing both the viral load as well as the NAT test. So the first NAT and the viral load has to be done 4 weeks after you interrupted the ART. If it's negative and viral load is undetectable, okay, you schedule the next one should be 4 months from the last time the baby received ART when you interrupted. And if the 4 months one NAT is negative and viral load is undetectable, the next one should be at 8 months. Okay, and that's the last month that coincides with the last month of follow-up of this baby. And if the baby at 8 months, the NAT is negative and the viral load is undetectable, you decide now, depending whether the baby is breastfeeding or not breastfeeding, for a final HIV test. If the baby is still breastfeeding, you follow up the baby and you do the final HIV test 6 weeks after the cessation of breastfeeding, depending on the age. So you need to use the appropriate test to establish the final HIV status.
Okay, thank you very much, Dr. Piri. So I'll just read out 1 more question. There are a lot of questions in the chat, but I feel some of these will be addressed as we go to the case presentation, which is the next item on our agenda. So I'll just read out this question quickly and ask on Dr. Mbewe to give us an answer to this one. So this one is coming from Engwira. How many positive results after interrupting are sufficient to say the child is positive? For example, if positive at 4 weeks, is there a need to repeat the tests? So I'll repeat this question. How many positive results are after interrupting are sufficient to say the child is positive? For example, if positive at 4 weeks, is there a need to repeat the tests? Dr. Mbewe?
Yeah, so when you get a positive result, you make a decision that the child is indeed HIV infected. Remember, this is a child who's already had another positive result in the past, but because they had discordant results, that's why you interrupted. But then when you stop the treatment, if they were indeed infected, the viral load will start rising. So if you get another positive result, then you should be able to say the child is infected and you recommence the treatment. You don't wait to do another test to get a positive result. Yeah. And in line with that, there was a question about why 4 weeks, why 4 months? Basically, the idea is to pick up the infection as you are getting your viral rebound. Someone asked what it was. Basically, your virus going up again as viral rebound. So you want to pick it up early. The 8 months really is the last point where you should be able to pick up the virus if the viral load is rising. But it's not going to rise suddenly at 8 months. It will slowly start rising. So you don't want to wait until 8 months for you to test. So there are these earlier time points. It's the 4 weeks, the 4 months, then you go on to 8 months, so that if it's rising by 4 weeks, you should be able to pick it up and recommence the baby on treatment. You don't want to wait for 8 months when everybody should have had their rebound for you to do the test. So that's why you have these other tests before the 8 months last test. I hope that answers a few other questions I saw in the chat. Thanks very much.
Thank you very much, Dr. Mwangelo. So we are going to go to our case presentation, but before we do that, I'll just share the pause once more as Dr. Patrick Lungu just prepares to give us our presentation. Madam Salisho and Madam Zumara, we are going to need you in the case presentation, so you're not forgotten. So I'll just share the pause once more and we'll quickly go through them as Dr. Lungu prepares. So our first poll question reads, which one of the following is not an effect on HIV-exposed infants due to in utero exposure to maternal HIV? A, increased risk of low birth weight. B, decreased infant mortality. C, intrauterine growth retardation. D, reduced head circumference in early life. So we'll give it a few seconds before we close the poll and share the results. Okay, Dr. Piri, the answers are coming in really quickly. Learning has taken place. Okay, just a few more seconds before we close and allow for a quick comment from our didactic presenter. Okay, we are going to close the poll now and share the results. So the majority of the network feels the answer is B. Just a quick comment, Dr. Piri.
Yes, so that's the correct answer. Because remember, the effect of exposure to maternal HIV during pregnancy has several effects, including A, C, and D. All these have been documented to be some of the effects. So B is the opposite actually. So there's an increased infant mortality, not decreased.
So we'll launch the second poll question and the network can call in. Okay, so our second poll question reads, which of the following is false? A, in Zambia, all HIV-exposed infants should receive cotrimoxaz or prophylaxis from 4 to 6 weeks old. B, the recommended ARV prophylaxis for HIV-exposed infants in Zambia is AZT3TC and nevirapine. C, according to the current national guidelines, all HIV-exposed infants should receive ARV prophylaxis for 24 months. And D, all HIV-exposed infants should be assessed for TB on every visit. So we'll give it about 30 more seconds before we close the poll and share the results. Okay, so we're going to close the poll now and share the results. Dr. Piri, your quick comment?
Yes, so the correct answer for this question is C, so the majority got it correct. So in terms of the guideline for provision of ARV prophylaxis, the guideline doesn't say it's supposed to give for 24 months, no. I think it's very clear in terms of breastfeeding and non-breastfeeding. So for those that breastfeed, a minimum of 12 weeks, right? And then you make a decision. If the mother achieves viral load suppression, you can stop at 12 weeks.
Okay, thank you very much, Dr. Piri. So share our third and final poll question. And it reads, Concerning early infant diagnosis, which of the following is true? A, in Zambia, confirmatory test for HIV infection in children more than 12 months old is serology test. B, the virologic test done at birth is able to pick the HIV infection that occurred during labor and delivery in a newborn. And C, virological rebound in HIV-infected infants starting treatment early is expected to happen within 8 months of interruption in more than 99% of HIV-infected infants. So give it a few more seconds before we close the poll and share the results. Okay, so we are going to close the poll now and share the results.
Yeah, so the correct answer is C. So the majority got it correct. So there's overwhelming evidence that more than 99% of HIV-infected babies that are on treatment, after interruption of treatment within 8 months, more than 99% of them, they actually record viral rebound. And that's why we follow them up for the period of 8 months. I think Dr. Moyana also ably explained on this one. Thank you.
Thank you very much, Dr. Piri. So Dr. Lungu, are you ready to present the case? And would you like us to share from here, or are you going to share from your end?
Hello, Doc. I am ready to present the case. It would be fine to share from here, but just so that we don't have network issues, maybe you can just share it from the hub.
Sure thing, Doc. Dr. Lungu, the floor is yours.
Thank you very much. Good afternoon, everyone. Dr. Lungu here with today's case presentation. Am I audible enough?
Yes, Doc, we can get you.
All right, thank you. Next slide. Okay, so this is a case of ML, a male 8 days, who was born on the 15th of June, 2023, born at term with a history of prolonged latent phase of labor, which concluded as a normal vaginal delivery with APGAR score of 910, 2.7 kg birth weight, and the place of birth was Cabo Central Hospital. Of note is that this was a mixed-fed infant whose mother is aged 29 years old, and she's a para-1, RVDR since 2010, who was also initiated on ART at the same time that she was tested positive in 2010 via the test and treat protocol prior to delivery. So she had been on ART for about 13 years prior to delivery. Of note is that the report she gave to the team that saw her was that she had undetectable viral load during pregnancy, even though she was not able to provide us with evidence of the same, owing to the fact that she started her antenatal at Mwese Clinic in Wapula, so her records were that side, and she ended up concluding those antenatal visits here in Kabwe at Kasande Clinic following a transfer from work. She otherwise had an eventful antenatal care period with RPR testing negative. And of note here again is that both parents are in formal employment in the civil service. However, the father on the other hand refuses. The father of the baby refuses to get tested for HIV and or start medicine. Due to that fact, these two parents have not been together ever since the pregnancy and was discovered. On medical history, this was a referral from Cassandra Clinic, who was brought in for management of neonatal sepsis. And at our facility, via the Kawe Women and Newborn Hospital, the child was admitted on the 23rd of June, 2023, and was initiated on ART prophylaxis at birth. Was found to have been initiated on ART prophylaxis at birth, and also a DBS was done at birth, but there were no results yet. On the 23rd of June, the patient came in with complaints of body hotness, rolling eyes, and inability to feed, which was related to the mother's retracted nipples, and a diagnosis of late onset neonatal sepsis was in HIV-exposed infant was made, and the child was started on gentamicin, Expen, full blood count was done, RPR, blood culture, dextrose 10%, expressed breast milk, and then the plan to expose the baby was also included, and the ART prophylaxis was to be continued. And this baby was admitted to the neonatal ICU. On the 27th of June, the baby was reassessed and was found to be wasted, which was also related to the poor feeding due to low milk production and the retracted nipples, which was found on the mother. In view of this, formula feeds were introduced, and also there were there were notable temperature spikes per chart, despite the child being on antibiotics for about 5 days, and hence the decision to switch to another antibiotic, cefotaxime, was made, and physio was to be started in view of the finding where the child was noted to have knee contractures bilaterally. Then on the 28th of June, the following day, the following tests were done on the neonate: a urine lamp, which was found negative, stooge expert, which was found negative as well. A NAT was done on the neonate, which was also found to be negative. On the 29th, temperature spikes were still noted on the chart, and the child was then switched to Kefipime. On the 30th, the patient was noted to have gained weight from 1.94 kgs to about 2.5 kg, and the temperature spikes had noted to have continued. And on this particular day, the same drugs that were already on the chart were continued, and the child was to be observed for any further changes. Later on the 1st of July, temperature spikes were still present, and hence high dose Kefipime and ciprofloxacin and tepid sponging was initiated. On the 3rd of July, an improvement was seen, where now the child was also switched to exclusive breastfeeding. On the 4th of July, there was a great improvement. The vitals had stabilized the chart, and the baby was actively playing. A decision to keep in was made to further observe the child, and then on the 7th, the child was found to be stable, and hence was allowed home on oral ciprofloxacin, cephalexin, and Calpol, and of course to the AZT, 3TC, and NDP prophylaxis was continued. Of note here on the other side, as you can see, dear network, you can see the physical examination, which was At the time of admission, the pulse was 138 beats per minute with a high temperature there of 39.3 degrees Celsius, and the weight was 1.94 kgs, and SpO2 94% on O2. Of note is that this child was saturating off O2, so the child was quickly put on oxygen. And the RBS 5.7, and the child was irritable and mildly wasted and had contractures, hence the decision to call in the physio team. On drug history, there was only the prophylaxis, the ART for prophylaxis, which was there. Next slide, please. So this is just a breakdown of the results that we were able to receive from the laboratory, and then also just the medications that were being given to this child during the course of his hospital stay. As you can see here, of note is that we did collect full blood count on the day of admission, which is on the 23rd, but we did only receive the results the following day with a white cell count of 3.4 and then HB of 13.7. Then later on, a repeat full blood count on the 4th brought out a rather high white cell count and then a reduced hemoglobin of 10.3. Then on the 7th, as the child was being sent home, as earlier discussed, the child was put on ciprofloxacin, cephalexin, and calpol. The NAT was done on the 28th and it was negative. RPR was also done on the 23rd and it was also negative. TB lumps, 2 gene expert were also done on the 28th, which were both negative. Next slide, please. So from this case presentation, we could only gather a few questions. The first was the nipple retraction a contraindication for breastfeeding in this case, in this HEI? And what other guidelines need to be followed concerning feeding in HIV-exposed infants? 2, what are some of the best strategies that can be taught to new mothers, in that especially this mother was a new mom. She did express having quite a challenge when attempting to feed, especially in view of her retracted nipples and all that. What are some of the best strategies to teach to new mothers about feeding of a neonate, and what are some signs to look out for as indicators of inadequate neonatal feeding? With this, I would like to end the presentation. Thank you.
Thank you very much, Dr. Lungu, for that case presentation. In view of time, I won't summarize the case, but I will allow a few questions from the network, just to clarify a few points before we can start tackling the questions. So if there are any pressing questions from the network, do kindly just unmute and ask your question, and then Dr. Lungu can respond to those quickly. Do we have any questions from the network concerning the case? Anything you'd like to clarify? Okay, if we don't have any questions, we can begin tackling the questions that have been asked by Dr. Lungu and the team. The first question is, was the nipple retraction a contraindication for breastfeeding this exposed infant? And what other guidelines need to be followed concerning feeding in HIV-exposed infants? Do we have anyone from the network who would like to attempt this question before we can ask our experts to step in? Okay, we don't seem to have any takers. Madam Muzumara, would you like to give us a response to this question to stimulate conversation?
Hello, good afternoon all.
Good afternoon.
I must say, apologize, network was a challenge. I was traveling to Lufonsa. However, I managed to follow the case. The first question, which is on a nipple retraction, is it a contraindication? I must say it's not a contraindication at all. But however, as nurses and midwives, we need to prepare our mothers antenatally. Anybody can do it. The baby does not suckle from the nipple. They suckle from the breast tissue. So this shows the lack of help that is coming from midwives. We need to help our mothers and to ensure that breastfeeding is initiated within the first hour of birth. At that time, the suckling reflex is quite strong. Otherwise, the baby would struggle if time elapses and the mother would get frustrated. So, and on breastfeeding, we need to encourage the mother to feed the baby often, 10 to 12 times a day, including night feeds. Thank you.
Thank you very much, Madam Zumara. Is there anybody else who would like to give another comment towards this question?
Okay.
Yes, Madam Selisho, please go ahead.
Thank you very much, Chair. So just to add on to what Madam Zumara has said, I think on the nipple retraction, just my response to the first question, on the nipple retraction itself, this mother attended antenatal at the facility, and during antenatal, women have a chance to undergo a breast examination. So normally during that process, when we encounter such, we are supposed to initiate education to this mother on how to help to maybe address that challenge that she has. During antenatal, we may take this as an opportunity to teach her on some practices that have known to be very helpful, such as the issue of rolling the nipple between thumb and finger, and then it will stick out eventually, and then to also compress the breast behind the areola in a C shape, such practices that we teach in antenatal classes. And then just adding on to other feeding guidelines that were to be followed concerning feeding of an HIV-exposed infants. In Zambia, noticing that we are a breastfeeding nation and we've implemented successfully the issue of ART in antenatal and in breastfeeding women, the guidelines is that the children have to be exclusively breastfed from 0 to 6 months. So then at 6 months, complementary feeds can be introduced. Then at 12 months, again, they have to assess if the feeding option is going to be feasible, affordable, and if it's going to be sustainable and safe for the baby, in short, AFAS. So at 1 year, they're supposed to do AFAS. And when they discover that the child, the mother has adequate nutrition, then breastfeeding can be stopped and child is put just on feeds. If not, then they have to continue breastfeeding with complementary feeds. I just thought of adding those, Chair. Thank you.
Thank you very much, Madam Salisho. I think you've actually managed to tackle question 2 as well. Perhaps there was some 2 questions in the chat for Dr. Lungu. If you could quickly just tackle these. What was the latest viral load result at Kasanda Clinic? And then there was another question about the weight of the baby when the child was brought in. Dr. Lungu.
All right, thank you, Chair. So for the latest viral loads from Kasanda Clinic, and unfortunately, we were not able to pick that from the antenatal that she presented to us. Perhaps that could be an action point, because an action point where perhaps the antenatal clinic, they need to take keen interest into such investigations as well, in that even them, they didn't have the records of the previous viral load and the CD4s and the whatnot. And then second question, what was the original weight of the baby at presentation? That was 1.94 kg, as as indicated on the second slide, 1.94 kgs. And then by the time the child was being discharged, there was close to about 30% weight gain, because there was close up to about 30%. It was, I think, 28.8% weight gain from the original 1.94 kgs. Thank you, Chair.
Thank you very much for those responses, Dr. Lungu. We have another question in the chat about whether the cause of the nipple retraction was established. Would you like to respond to this one as well? Lungu?
So about the nipple retraction, of note is that these nipples didn't seem to retract due to any pathology, really. I would, in my own assessment, I would take it to say that was just her natural shape of nipples. They were not really protruding to allow the mother to allow the baby to grip onto the breast properly. Not that there was any pathology per se. No. It was bilateral nipple retraction without any obvious signs of breast pathology. Thank you.
Thank you very much for that response. So we are running out of time, and I hope Dr. Lungu and the CAWA team, the responses given by Madam Zumara and Madam Selisho do suffice for this case. Were your questions answered?
Yes, Chair. My questions have been actually answered. They have been actually reminded on the necessary protocols, and also the technique of the nipple and finger, the thumb and finger rolling of the nipples. I think that's very much important. That actually even other districts, other facilities can actually take advantage of, just to teach these mothers so that we don't end up with such problems.
Okay, great. Thank you very much, Dr. Lungu. So I'll ask Dr. Piri to just summarize for us, and we will close this session after that. Dr. Piri?
So thank you, Network, and very interesting contributions there. I enjoyed the discussion, and the case was very stimulating. Brought out quite a number of important issues to remind ourselves in terms of managing pregnant women, including the exposed infants. Just a word or two. I think the last part of the question was, how do you identify, how do you suspect, what are some of the early signs that you look out for in a baby that should show that the baby is not feeding adequately, or there's evidence of inadequate feeding. So we know that what we expect if the baby is feeding well, no any other underlying issues, the baby should be gaining weight, right? So that's part of growth. So if the baby is not gaining weight according to expectation, when you look at the velocity, when you look at the under 5 card, you find that there's weight faltering. First thing that you suspect is the baby feeding adequately. And in the history, especially the prime gravida, the first mothers, you want to make sure that the mother understands in terms of the appropriate positioning, and also understand that the baby gets full after feeding. Because sometimes you find that, yes, the mother may be having enough milk, but the position is poorly, they're poor latching. So you want to find out, generally, when the baby is full after sucking, the baby is expected to go to sleep, okay, and wakes up probably maybe after an hour or two, and then starts sucking again. But there are situations where in the history, you get to know that this baby only sleeps maybe for 10 minutes, 15 minutes. The first thing that you need to suspect that the baby is not getting enough milk from the history, and that can be good pointer to also add to the suspicion that the baby maybe not be getting enough nutrition or inadequate feeding. Apart from that, you can as well look out for other pathologies or underlying conditions or any infection that could affect the baby from getting enough feeds. So otherwise, from our end, I think we hope that we've gotten one or two issues in terms of management of exposed infants. Remember, our goal is for the PMTCT is to ensure that we reduce the mother-to-child transmission of HIV. Since it's a breastfeeding nation, we want to reduce it to less than 5%, okay? And that is doable, and that less than 5% is not at national level alone, no, should be every district, every facility. That should be the goal. Thank you.
Thank you very much, Dr. Piri. And with those words, we'll close this session. I know some questions and some comments haven't been responded to in the chat, but we are going to have another session at some point for PMTCT, and these will be addressed. The iEcho registration link has been shared in the chat. Please do register on that link. You will only be required to register once, and whenever there's a session for ECHO, actually a reminder will be sent to your text or your email as well. So thank you so much, everyone, for participating and for your presence as well. Enjoy the rest of your day. Thank you.